I would like to start the presentation of today as part of the medicine grand rounds, as I mentioned. The title of my talk is Thrombolytics and Neuroprotection, the yin and yang of neuronal survival in stroke. I have no financial disclosures. These are the learning objectives. I'll try to provide a historic and current data review on existing stroke thrombolytic treatment paradigms, in addition to future development of the so-called DREAM compound. I also touch upon the existing potentially effective neuroprotective treatments and the mechanism of neuroprotection in acute stroke. I'll discuss the Maimonides stroke program research initiative, including the TNK-TPA comparison study, and also the neuroprotective effect of aminocycline. You may wonder why I say thrombolytics and neuroprotection are the yin and yang of neuronal survival in stroke. That's because I think they are the two most fundamental factors and also the basis for neuronal survival in a hostile environment of ischemia and infarction. The neurons need a constant energy source delivery to survive, which is conveyed by constant blood flow. When the blood flow is decreased or lost, the energy source is in crisis for neurons to survive. In the meantime, so the thrombolytics will achieve the restoration of blood flow energy delivery through lysing of the clot. In the meantime, neuroprotection is needed to sustain those neurons that are ischemic but not actually dead, so they can give us a chance to revive them. Without either, you won't have a viable brain. That's why they will affect the outcome of the stroke patients. So that's why they're yin and yang of two fundamental important factors for neuronal survival. So over the years, there have been a number of thrombolytic agents developed. About 3 generations. Initially, the urokinase, pro-urokinase, and also streptokinase developed from urine and kidney, and also from the bacteria Streptococcus. They have thrombolytic agent properties to lyse the clots, but they are fairly non-selective. So it will cause potentially other side effects such as hemorrhage elsewhere, less target to the clots. The second generation is the thrombolytic treatment is exemplified by the alteplase, which is a tissue plasminogen activator that binds to the fibrin with different degree of selectivity to cleave the plasminogen into plasmin that function as a scissors to chew up the fibrin, which is the building block of clot, to dissolve the clot. So there are a number of tissue plasminogen activators developed besides the alteplase, which is also called TPA in clinical use. The third generation, which I will talk about heavily, is the tenecteplase, so-called TNK, which you can consider a Superman version of a TPA, which has interesting properties and which I will go in more detail later on. Desmoplase, I will not focus on too much about, just suffice to say that it's also tissue plasminogen activator derived from bat saliva. It has been studied in the clinical trials. However, it has the property for the highest fibrin selectivity. However, it does not actually have much interaction or capacity for plasminogen activator inhibitor interaction. In a way, it can say it's a medication with the on switch where it's target selected but doesn't really have the off switch. So part of the reason is clinically it has caused different rate of hemorrhages in clinical studies, and different doses is being studied to see whether we can achieve a safety and efficacy sweet spot. That's being done. The hope is to, by adjusting the dosage, maybe we can expand the treatment window beyond the 4.5 hours right now to up to 24 hours. So when you talk about thrombolytics, you cannot not talk about the 8-pound gorilla in the room, which is TPA, alteplase. It has been the blockbuster and clockbuster for the last 2 decades, more than 2 decades. This is initially approved in 1996 by FDA. So it is a serine protease that cleaves the plasminogen into plasmin. That's the active medication that's the component that lights the clot. It's given by IV bolus 10% of the dosage, weight-based 0.9 milligram per kilogram, in addition to 90% infusion within an hour. Intraarterially, it can be given to the target vascular territory, typically between 10 to 20 milligrams per vessel, although it's been reported that the whole IV dose 0.9 milligram up to 90 milligram have been given intraarterial as well with relative safety. And it's approved by FDA in 1987, initially for acute myocardial infarction, followed by 1990 for pulmonary embolism, those massive PEs, and in 1996 for acute ischemic stroke after this landmark New England Journal study by the NINGS TPA trial. In that trial, in December 1995, the investigators, including our own Dr. Steve Levine from Maimonides and SUNY Downstate, demonstrated in actually a 2-part study. Initial first part showed signal but didn't achieve efficacy because of the small size. They actually have to do a 2nd-part study to demonstrate the efficacy significance. So in this landmark study, TPA was given to patients with symptom onset less than 3 hours, with NH more than 4 in adult population up to 18 years above, without upper age limit. In that study, actually they were able to demonstrate more than 30% more likelihood of good functional outcome by 90-day period, defined by the modified ranking scale of 0 to 1, which is functional stroke scale defined by essentially no symptoms or mild symptoms without disability, have the independence. So in the study, there's no effect on mortality for the treatment and placebo group. Probably partly because the heterogeneity of the study group are so relatively small. We know actually thrombolytic agents can actually affect mortality in large vessel occlusion patients. The symptomatic intracerebral hemorrhage rate for that study is reported at 6.4%. And based on this landmark study, FDA approved TPA use for acute ischemic stroke, which fundamentally changed the treatment paradigm for stroke since 1996. And the treatment window was further extended to 4.5 hours after this ECAS-3 study. Is a European study published in 2008 of September, chaired by the ECAS-3 study group by Dr. Hankey. So in that study, 821 patients was randomized to the treatment group, was a placebo group of TPA with symptom onset between 3 and 4.5 hours. And as again, more than 4 age is between 18 to 80, and without the evidence of prior stroke or concurrent diabetes. And also NA stroke still has to be less than 25. You can't be too severe. These criteria are designed to limit the hemorrhagic conversion rate because it's given for a later time frame. And during the study, it was shown that there's 52.4% good functional outcome compared to the 45.2% outcome in the treatment group for the placebo group, respectively. The odds ratio favoring the treatment group is 1.34, again, achieving more than 30% of functional improvement. No significant difference between the groups for mortality again. In this case, the symptomatic intracerebral hemorrhage rate is documented at 2.4%. It's slightly lower than the initial NINGS TPA trial. So when we talk to patients and family, we typically code these numbers, the complication rates between 2.4 and 6.4% for hemorrhage. The symptomatic hemorrhage is defined by NIH stroke scale change or worsening more than 4 or other studies. However, the treatment window for 3 to 4.5 hours was never approved by FDA because of lack of American study, because remember, this is a European study. So we have been, in clinical practice, has been using that the window from 0 to 4.5 hours as a standard of care for since 2008. It's been endorsed by the American Heart and Men's Stroke Association and all the clinical guidelines. I'm sure you have heard this phrase, time is brain. And why is that? One is because, as I mentioned above, there's a finite treatment window for these acute stroke patients. Beyond that window, the patient will not be eligible to receive this effective treatment. That's number one, right? But that's not the most important, because physiologically, the ischemic neurons will not take very long to die without blood supply. It takes less than 5 minutes for the neurons to go under apoptosis, cell death, without blood supply or an energy source, not hours, right? So that's something that every minute counts. We want to save as many neurons as possible, which I will talk about the speed of infarction and cell death as well. So we know time is brain. So people have been creative. We need to have a CT scan done or imaging done to distinguish between ischemic stroke from hemorrhagic stroke before we can make a decision for thrombolytic treatment or not, if they are within the treatment window, right? So the sooner you can give that IV thrombolytic treatment, the patient will have better outcome. However, you need to have a CAT scan done first. Clinically, you can't really distinguish reliably with 100% certainty between the ischemic and hemorrhagic stroke. So how do you do that? So folks from Germany initially, and also from UT Houston, chaired by Dr. Jim Gorta's group, came up with this brilliant idea of mobile stroke unit. So this is the ambulance you can see with a mobile CT scanner in the back of the truck, right? So you can get immediate CAT scan at the site of your patient contact before you have to drive the patient back to the nearest emergency room, stroke center. So that image can be transmitted online to the on-call neuroradiologist to have a rapid read. In the meantime, you can see there's a monitor with a tele-stroke doctor to do the clinical evaluation to determine the eligibility of the patient based on the imaging study which is acquired to determine eligibility. So this has actually tremendously improved the efficacy and time to so-called, I wouldn't say door to needle, but contact to needle time. This is again illustrated by the New England Journal article by Dr. Gorta's group, demonstrating that the mobile stroke unit can actually save more than 30 minutes from the time the patient called for 911 until they receive the IV thrombolytic treatment on site before they transfer. And also there's benefit of having the CT study done to allow actually the hospital teams to be prepared for additional intervention if needed. So that's the other added benefit. The thrombolytics is great, but it's not one size fits all. They can solve all the problems. It has limited great capacity to dissolve clot in small and medium vessel clots. But for large vessel occlusions where there's lot of clot burden, the IV thrombolytics actually worked miserably, especially distal internal carotid artery or cervical carotid artery occlusions or basilar artery occlusion. It worked only less than 5% of the time. In other words, the clot burden for these large vessels are so big that the TPA or TNK will not dissolve the clot. The enzymatic reaction becomes infinite because the substrate is too large. For distal vessels, distal middle cerebral arteries, M1, cyclin M2, it's about 30%. And this has been also demonstrated in the lab when they actually examine these clots and on imaging studies and also on the post-thrombectomy studies that any clot size more than 8 millimeters will not lyse. The 10 is actually is the cutoff. So 1 centimeter lens clot will not lyse by the thrombolytic agents. So that's where the mechanical endovascular surgical treatment comes into play in combination or besides the IV thrombolytic treatment. The size is not only the story, also the composition of the clot also matters. There's so-called the red clots or the white clots. The white clots are so-called the fibrin-rich clot. It's like a package densely packed with a lot of fibrin. You can imagine it will take the thrombolytic agent TNK, TPA a lot of time to chew out this fibrin to release the clot, as opposed to the one on the right side, which is rich in red blood cells and as sparse fibers. The substrate is much less. It's not easier to remove these clots, lyse the clots. But the red clots tend to have a tendency of destabilization because they are fragile. So when you do endovascular stent retrieval treatments, so they may embolize distally. That's why we use aspiration in combination with typically stent retrieval. Now, the third generation of thrombolytic treatment, the tenecteplase, is genetically modified with 3 residues, protein amino acid residues, to offer much higher fibrin specificity and target level with the different half-lives. It's given instead of IV bolus plus infusion, it's given as a 1-minute push. It's weight-based 0.25 milligrams per kilogram current recommended dose. Studies show that 0.4 milligram per kilogram dose actually will cause risk of hemorrhage. That's not acceptable. It's endorsed by the American Heart, American Stroke Association as a reasonable alternative thrombolytic treatment to TPA. FDA approved the medication for acute MI again in 2003. Again, not approved for ischemic stroke because there's no American randomized trials done for the same reason. So we have been, many people actually, many programs worldwide and including in the US have been switching over to tenecteplase because of these real world data and meta-analysis showing possible, at least non-inferiority in terms of both safety and efficacy of tenecteplase compared to TPA. Maybe even safer and more effective, which I will talk about in our research later on. The other benefits is the cost. It's about 1/3 of the cost of TPA if you have the same milligram dosage, although the package is different. So the manufacturer is always there to maximize the profit. So this is a meta-analysis by Dr. Jeffrey Saver from UCLA and Adrian Burgos, analyzing 5 randomized trials with TPA and TNK. Comparison internationally, which basically showed non-inferiority any way you want to look at this. So it's fairly comparable. That's in other people's mind, including neurologists, stroke neurologists, change their kind of mind to move them away from the TPA. So we didn't want to just simply copy other people's footsteps without testing our hypothesis in our own population, because our community is quite different, as all of you know, who's sitting in the audience. I think we have one of the most diverse zip code in the country. The heterogeneity of our population is very different than somewhere else in the country, and also elsewhere in the world, of course. We also tend to have an older population for our stroke patients as well. So we want to test these 2 medications in our own stroke program, which we started last year from January to December and completed the study as a part of the quality initiative in April. Once we have the 3 months modified ranking scale functional data available. As you can see, last year we gave 56 patients IV thrombolytics. 18 of them chose TPA, and 38, 2/3 of them chose tenecteplase. They are both available. We're giving them the caveat of FDA approval and the current data, also the standard of care recommendation. So the patient and family has a choice. But often one of the most common reasons, besides they're saying, I know the study and I want to try the new things if it's better, they often typically ask, Doc, what would you do if this was your family? If I'm your family, which one would you choose? So we typically say either one will work, but there's increasing evidence suggesting maybe tenecteplase may be safer, at least the same, equivalent, if not better. So that could be part of the reason, the so-called treatment bias that driving this twofold change difference between the TPA, TK data. But what I want to really draw your attention to is that despite, actually the other point I want to make is that the TNK group actually has a much faster door to needle time. It's actually 20 minutes faster compared to the TPA that we give. The same clinicians, same discussions, but I think once you have the two choices, in the past people have the choice of yes or no, you want to receive thrombolytic or not. These days, nobody say no anymore when you're eligible, but you have to decide which one. I think the TPA group, for some reason, took longer. They tend to be slightly older. The median is 75 as opposed to 68. Maybe they are more conservative, safer, who knows? But we don't, the number is too small to achieve statistical significance over here for age. But the most remarkable thing to us is that if you look at the two groups, their stroke severities are vastly different. The NIH stroke scale, which is a measurement of deficits on presentation, is much more severe in the TNK group, 15, as opposed to the NIH5 and the TPA group. The NIH5 is the typical group for the TPA study. In the NIH NING study, the average median TPA, the NIH is about 6. So that's in a similar group. But for this TNK group, they are often similar to the large vessel occlusion type of stroke patients, right? So despite the severity differences, we are achieving essentially the same outcome for clinical functional status for these patients at 3 months, as well as hemorrhage rate and death rate. So you can probably flip side saying that despite the severity, which you would expect a worse outcome, but actually we're able to achieve the same outcome. So to me, the hypothesis generated from this small group study would suggest that tenecteplase may be more effective in treating more severe strokes, including those LVOs, than TPA with similar safety profiles. And an easier administration may be one of the reasons that can lead to faster door-to-needle time, but tenecteplase and TPA to actually contribute to the possible better outcomes. So these are the study conclusion we have. Based on that, we have made the decision as a program to switch from tenecteplase as our own the sole IV thrombolytic agent in April. The TPA is still available for intra-arterial use for adjunct treatment besides the endovascular approach. So what are the future targets for enhancing thrombolytics, right? You want to, hopefully one day we'll find a compound that can lyse the clot no matter what time of symptom onset. That's still safe and effective, right? So there are different targets, the glycoprotein 1B and the glycoprotein 6, 1-Willebrand factor, these, and also 2B3A, which is part of the most trial that's ongoing right now, combination of 2B3A inhibitor along with IV thrombolytic treatment, both TPA, TNK allowed, and also neutrophil extracellular traps. All these are part of the thrombus complex that we are targeting from different angles. Maybe one day you have a compound that can target all these things, synthetic compound. And actually, maybe we are very close. This LT3001, developed by the Lumosa company based in Taiwan, actually presented their preliminary data phase 2 clinical trial of a synthetic molecule with both thrombolytic and neuroprotective properties that can be given up to 24 hours from symptom onset with no hemorrhage. Their phase 2 trial has 0 intracerebral hemorrhage, which is remarkable. Small studies, but they almost achieved primary functional outcome improvement, endpoint, but not big enough. So their phase 3 trial is being, planned and organized. If that's done, they will again fundamentally change our treatment paradigm going forward. Maybe there'll be more. I told you before that IV thrombolytics is not the whole story. And oftentimes for the LVOs, we rely on endovascular approach in combination of IV thrombolytics to recanalize vessel to restore the blood flow for energy delivery to these neurons. These 5 landmarks interventional trials overwhelmingly demonstrated efficacy of endovascular treatment, in addition to or besides IV thrombolytics. You can see from the recanalization rate, which is defined as TK3 or 2B, is complete recanalization or more than 50% recanalization. We can achieve up to 90% of the time. However, our functional outcomes for better or good recovery is actually defined 0 to 2 modified Rankin scale. It's still hovering around 40 and 60% range. So there's discrepancy of recanalization and good functional outcome. Why is that? I think we focus as a society, as a field, very much on trying to decrease the infarct size. The thrombolytics and also the endovascular treatment are designed to restore flow to decrease infarct volume. However, I think we should pay more attention on the location of the infarction too. A brainstem infarct and also the basal ganglia, internal capsule infarct, thalamic infarctions, even though they may be small, they could be devastating, right? So we may have to look at these different locations to, come up different triaging or measurement paradigms that reflect the size, because we're measuring a composite, but only targeting one of the composite parameters of size. There's probably more story beyond just recanalization. So this is the article that opened our eyes as a field, and especially as neurointerventionists, right? The CHOICE trial recently published in JAMA Neurology demonstrated that intraarterial TPA infusion at the 0.225 milligram per kilogram dosage, 15 to 30 minutes for continuous infusion after mechanical recanalization. When you achieve TK2B or 3 recanalization, you don't stop there. You continue the infusion for this intraarterial thrombolytic treatment for another half an hour at this dosage. You achieve an 18.4% absolute functional outcome improvement, which we've never seen that big. So the immediate recanalization is not the whole story. There are all these so-called stunned brain or so-called misery perfusion after we open the vessel, because the neurons are stunned. They're not dead yet. The stunned, their metabolic profile is so different. So the blood flow over there does not actually transit the path. They become stagnant. They have so-called post-thrombolytic additional embolic events, as well microembolize. So maybe these thrombolytic treatment post-thrombectomy will actually clear off these junks to promote perfusion post-embolization, post-endovascular treatment. And actually, interestingly, it actually caused decrease of the mortality, although not statistically significant because the small number. So almost half of the mortality as well, which is interesting. So this hopefully additional larger trials will be sufficient to demonstrate and for this to be the standard of care going forward. You have an intraarterial infusion besides intravenous treatment for stroke going forward. All right, I think I've talked enough about thrombolytics. Let's touch about the neuroprotection briefly, hopefully, in the next 10 to 15 minutes. Just like many of us in neurology, we have been very frustrated with research on Alzheimer's disease, dementia treatment, or the neurodegenerative disorders. We spend so much energy, resources, and research efforts on that. We understood quite a bit about the neurobiology, but clinically, we haven't been able to achieve effective, targeted treatment that's clinically used after so many years. Neuroprotection is another example that if you, as of last night, I did the Google search on the clinical trials on the clinicaltrials.gov. There have been 240 clinical trials designed for neuroprotection. And among them, 93 are stroke-related. And to this day, we don't have a single neuroprotective agents or paradigm clinically for stroke that's effective. That's widely accepted in clinical practice. I mean, minocycline may be exception, because we have, at this institution, we have been using that for some time until we didn't. And that triggered our research. Actually, we stumbled upon something which could be fundamentally important as well, which we'll talk about. So besides minocycline, uric acid, azelaic acid, also hypothermia, flavonoid, magnesium, cannabinoid, nitric oxide, all these targets have been, potential candidates have been studied extensively in animal models, clinical research. None of them pan out to be the golden boy. And uric acid may be as the a promising candidate as well. But I hope minocycline will regain its popularity. So you'll see why. I cannot talk about neuroprotection without talking about the natural protection many of us have. That's called circle of Willis. The circle of Willis is only present in higher order mammalian creature species, not in the amphibians or in the birds, insects. It's an evolutionarily conserved, selected vascular structure in the brain that can provide collateral flow in case, I'm sorry, the picture is a little blurry. This is circle of Willis. This is the carotid artery, anterior cerebral artery, that's anterior communicating artery, and that's a communicator between the internal carotid artery with the posterior cerebral artery, so it gives a circle. Imagine if you have a blockage of the internal carotid artery over here, the blood flow can come from the contralateral internal carotid artery, cross over from the anterior communicating artery, go into the distal middle cerebral artery, providing the adequate flow. Similarly, it can come from the ipsilateral posterior communicating artery from the posterior circulation of vertebral basilar system and providing the flows. As well, they can go from the anterior circulation to the back too, especially you have a basilar occlusion. The top of basilar vessels, these perforators are critically important. They are supplying the thalamus brainstem that are important for reticular activating system for arousal. So that's why people can go into coma after thalamic stroke or brainstem stroke, so-called lock-in syndrome. It's because these perforators are affected. But if you do have the communicating arteries, you can supply the top of basilar, even though you have proximal occlusion, the blood flow can flow backwards to supply these vessels. So that's the built-in safe key mechanism protection. So anatomy is key, especially for us interventionalists. That also defines who are the candidates for intervention, right? those who have good collaterals are the ones have most viable tissue, despite time lapse. Those who do not have collaterals, I don't care how fast you are as an interventionist, as a program, you cannot open a vessel within 5 minutes. Neurons will die. So that's why we see these ultra-fast progressors. When they come in within an hour, the whole hemisphere is gone because there's no collateral flow. Those candidates, those people will not be candidates for intervention or IV thrombolytics because those brain are irreversibly damaged, gone. And if you do anything potential, you can harm the patient by converting ischemic stroke into a hemorrhage, right? So anatomy is key to determine eligibility candidacy for treatment. Now, I want to focus on the next 5 to 10 minutes, focus on minocycline. So minocycline is a semi-synthetic tetracycline derivative small molecule that readily cross blood-brain barrier. This is very important. For something to be neuroprotective, it has to be able to cross blood-brain barrier to be easily delivered and to exert whatever effect it has, right? Naturally, it does. And it's one of the few neuroprotective agents in animal models, and also in clinical studies to be promising for neuroprotection. Not only just stroke, but also other neurodegenerative disorders for Parkinson's disease, spinal cord injury, ALS, and also MS too. So there are a lot of studies on minocycline out there for the different neuronal injuries. The proposed mechanism for minocycline protection is through twofold, mostly anti-inflammatory effects through inhibiting of the inducible form of nitric oxide synthase. Nitric oxide can be a double-edged sword for neuronal survival, and P38 mitogen-activated protein kinase reduction, which actually will reduce the glutamate toxicity, and also through inhibition of microglia activation. Microglia activation is important for the later stage of recovery to clean up the stroke site, but initially can be detrimental. And the anti-apoptotic effect of minocycline can be accounted for reduction of caspase-1 activation and downward regulation cytochrome C release from mitochondria, which is your energy factory of the cell, and that actually changes will potentially cause the disintegration of mitochondria and membrane, cellular membrane, and apoptosis. Inhibition of ADP ribose polymerase at the nanomolar levels, very effective. This also has been shown to decrease matrix metalloprotease levels, especially at MMP9, which are elevated during the ischemic stroke and TPA administration. And the good things about minocycline is that its medication has been widely used in clinical use since 1980s. It's been used for treating all kinds of infections, including acne for long-term, high dose, with very few side effects. The most, other than sensitivity or allergy, the most severe side effects is the kidney injuries, and besides some photosensitivity like leukocytic, symptoms associated with tetracycline and all these derivatives. It's very cheap, widely available. One dose of oral minocycline costs less than $1. So it's good to do the study and clinical use, and so all these good properties. And this is the kind of a very interesting study in 2007 that caused a lot of attention for stroke by Lampo's group, in which they published in Journal of Neurology, the Green Journal, in which they randomized 102 patients to minocycline treatment or no treatment. They have evaluated a blinded study for 5 days with 200 milligrams orally, given to the patient from stroke onset from 6 to 24 hours. And the primary outcome was at 90 days, one modified Rankin scale bottom index scores at 90 days, so another functional outcomes. So this is the efficacy of aminocycline. So this is a line graph showing aminocycline treatment group compared to the control group. From day 3, you start a deviation. You can see a much higher percentage patient in the treatment group, up to 25% at day 3 will have an NA stroke scale reduction, which is stroke severity reduction more than 4 points. And that line continue to be separated and deviate up to 90 days. So they can achieve neuroprotective effect very quickly. And NA severity, percentage mixture is also quite astonishingly different. So on top is aminocycline group, you can see the black bars are the good outcomes, 0 to 1, and the shaded bars are the higher severe outcomes. So you can see the aminocycline group was much more than the control group down below. The same thing for the modified Rankin as well. So that also, I think, based on the study in 2007, the program at Maimonides at the time was chaired by Dr. Steve Rudolph, who was visionary, decided to put aminocycline in clinical use routinely, both ischemic and hemorrhagic strokes. So we've been using that for the last quite a number of years until recently, in 2019, when Dr. Rudolph left, we did a program-wide faculty conference review of the evidence at the time. This is the only kind of the most promising study. There's no other additional randomized studies to support evidence. We decided to actually stop the usage as a program ubiquitously at the time in about March or April. And then shortly after that, COVID hit in the beginning of 2020. And we started noticing there's slow creeping up of our stroke patient mortality. Our other treatment paradigm, our staff, our selection criteria or technology hasn't really changed much. The only program-wide changes besides COVID was the aminocycline discontinuation. So we look at the period before and after aminocycline discontinuation around March and April. We see actually, this is the patient characteristics. We have about over 1,900 patients between January 2018 to March 2019. Before the COVID, there's another 420 patients to the end of the 2019. And after COVID in 2020, we have about 1,900 patients as well. So we have actually, remember last study we showed you had 140 patients, 42 patients, 52. And over here we have overall about 3,000 patients, more actually, 4,000, almost 5,000 patients. So it's a much larger scale study, right? And these are the characteristics patient. So among these things, you can see the age slightly younger over the years, a couple years younger, which is actually statistically given the median age. And you look at the overall mortality. Before we were on the aminocycline, the mortality is overall, both ischemic and hemorrhagic stroke was about 8.6%. But April to December 2019, after we stopped aminocycline, the mortality increased to 12.7%, and it continued to increase in 2020 as well. And it's statistically significant. And we look at the transfer patient, which are outside patient, and also our in-house patient. So the transfer patients, you see the increase as well, but the number is too small to make statistical significance. We do see the in-house patient, the mortality change is real. And we did a statistical analysis. So if you use the minocycline treatment group in 2018 to early 2019, the relative odds ratio of mortality in the 2019 patient before the pandemic is 1.58% overall. So close to 60% increase in mortality for these patients when we stopped minocycline. And yes, our admissions and then stroke scale is slightly, these patients are worse, right? Their age is actually younger. So the similar trend like persisted in 2022 actually is 80%, 1.88% increase as well. That may contribute to COVID. So if you look at group analysis, if you look at the ICH group, the statistical significance actually remained. It's actually bigger protective effect is 70%. And if you look at the ischemic stroke, it's about 1.4%, 1.38%. However, because these the study group between April to December is relatively small, we lost the significance value, but the trend is certainly there. But if you look at overall mortality, the statistical certainly is over there. So it seems like, contrary to some previous study that minocycline affected functional outcomes, in our study, actually, we observed across the board protective effect for minocycline in all patient population, ischemic hemorrhagic. So, but again, this is not, it's a retrospective review, not a prospective multi-center placebo-controlled study. So that's something we'll plan to move forward to in the near future. I wanted to thank our team of clinician research team over here. Amrita is a volunteer scholar from India who has been instrumental in conducting the study, especially the minocycline study, and prepare some of the presentations. She's very talented. She's looking for neurology residency. And if you have any vacancies, please reach out to her. Dr. Ida Levin is our critical care specialist, director for critical care over here, who will also speak today. He's also instrumental in our study, especially she's interested in hemorrhage profile. Dr. Sensory Mishra was our associate program director and for research and education. Now she's moved on after having a baby to New Jersey. So we wish her well. And she's also part of the study group as well. And Michael Silver is our biostatistician. We wouldn't have done this without his tireless help, his expertise. Barry Brima is, as you all know, is our program coordinator. I wouldn't know what to do without Betty. So he's my go-to person. Anything I have a problem, I'll go to Betty. For quality issues and organizing the symposium, anything. So Betty can solve any problem. You have a problem, give Betty a call. Is Betty over here? I want to give Betty a round of applause. Thank you, Betty. And Steve Levine, as I mentioned, who's a world-renowned stroke neurologist researcher at SUNY Downstate, who also my mentor at Mount Sinai and down at MIMO. He's also the one of the initial NIH LINCS TPA study investigators, landmark study that changed the stroke treatment paradigm. And Steve Levine also is my mentor as well as a fellow. And I actually rotated at Maimonides in 2009. That was my first encounter of Brooklyn patients. It's like coming back home in 2017. Without the visionary Dr. Rudolph, who established the first stroke unit, stroke program in Brooklyn and took us to the comprehensive designation in 2017, we wouldn't be here to talk about what we did. So Thank you, Dr. Rudolph, Dr. Levine. And also, I have to mention Joyce Chen is our research coordinator, our research analyst who's out there registering people. Thank you, Joyce. Dr. Jason Brady is our director of pharmacy, who has been very supportive and interested in the pharmacological study of both TP and immunocycline. Brittany Taylor is also a pharmacy resident, PGY1, interested in the study and primarily did the work on the TPA TNK analysis. Galina is our stroke team leader, Dr. Galina, DMP, very talented and dedicated. And Marina is also our NP, who's instrumental in our research efforts. We also conduct our own research. We participate in the National StrokeNet NIH-sponsored multiple trials, including SBAR, Arcadia, and Sleep Smart, as well as the most recent Captiva. So if you have any patients, please send it to our way. We look forward to collaborate with you. I'll stop here on a mark. You have, I think there are a couple questions on the audience. I'll stop sharing. Anybody had questions in the audience? Betty, can you send the microphones to the questions asker? Whoever had questions, one over there, one over here. Thank you. Please introduce yourself.
Gary Friedman, neurologist at Birkdale Hospital. In the beginning of your lecture, you had a list of the thrombolytics, and you had PAI-1. What is that, and what is its importance, please?
Yeah, the PAI is plasminogen activator inhibitor. So that's considered the off switch. When you have TPA, other things, you have something to stop the pharmacodynamics, right? So otherwise, you will keep lice in the clots and cause tissue problem. So that property is also important. Right. Yep. Another question.
Yeah, hi, Greg Gooden from MIMO. Have a quick question. So for people who get thrombectomy and then like TPA or TNK, have anyone looked into, is it more efficient with red clots or white clots?
Yeah, that's a great question that actually has been studied. People have asked the question for a long time. After the 5 trials I showed overwhelming evidence, so-called bridging therapy have TPA, TNK, and in addition to that. So why not, if you talk to a cardiologist, they're not giving TPA anymore, TNK. They just go take them to a lab, right? Bypassing the IV thrombolytics because we are as good as the thrombolytics to open the vessels. We can open 90% of the time, sometimes 95% of the time. It's not an issue anymore. So why waste the time for the TPA and instead of going there? And also TPA TNK can complicate things if you need, say, proximal stent, or you have other increased risk of complications, right? So I'm all for bypassing thrombolytics going forward. That's what I think was going to happen. The study have shown actually increasingly from China, from Japan, elsewhere, the US is we're slowest because the infrastructure, we're a bigger ship, it takes longer to turn as all the other countries doing their own study population. So that's probably going to be the future, just direct thrombolytic treatment with probably post thrombectomy intraarterial infusion. So if I want me to predict one paradigm going forward, I think that's going to be the way going forward. Great question.
Yeah, Dr. Grishina, here.
Okay, yes.
Internal medicine. Do statins have neuroprotective properties? Statins. Did you look at the statins as a neuroprotective or not?
Yes, statin is probably one of the most studied drugs on the planet Earth. So it has been tested for anything you can think of, including neuroprotection. For stroke therapy, I think there are certain benefits in certain ways, but not necessarily protection, but maybe other anti-inflammatory response and things like that, besides cholesterol lowering property. So it has been looked at as well. But nothing is earth-shattering or overwhelming to the degree we saw with minocycline.
So another question regarding minocycline. You were using it in your studies. Is it 5 days after the recanalization, or it's continuous for longer period of time?
So if you look at the studies, there are different studies using different doses. Some, 200, some are 400, some oral, some IV, some in 7 days, some in, 2 months, other people continuously. So there's a lot of heterogeneity over there. In that study, I mentioned in LAMPO study, they used 200 milligrams orally for 5 days from symptom onset 6 hours to 24 hours. So basically you give the patient on a day of presentation and continue for 5 days and stop. So I think that's a simple regimen. That's the one we've been using until we stopped in April 2000 or March 2019. So that's the paradigm. I think that's in a way important. The dosage important. And the duration is also potentially important. The way of delivery may or may not matter because it readily is absorbed across the blood-brain barrier for oral form. So there may not be a huge difference over there. But yeah, great question. Dr. Chen.
Dr. Gary Chen from Berkeley Internal Medicine. In your Maimonides experience of TNK, and I saw a few cases on either aspirin or Plavix. And do you think the aspirin provide like a primary prevention or make your TNK and easier or better effect or causing more side effect?
Good question. So aspirin or antiplatelet therapy is not contraindicated before the TPA was given. So if you are taking that as outpatient or before presentation, that's not contraindication. Eliquis or anticoagulation with warfarin, they'll be excluded, right? So, but we don't give them the aspirin or an antiplatelet therapy within 24 hours post TPA because of the fear of hemorrhagic conversion and the pharmacokinetics affiliated with that. So that's a protocol. So we don't do that. There are studies looking into to see whether early antiplatelet therapy after TPA actually may be beneficial. We don't have data to say either way, but there are studies looking into exactly the question that you're asking. Long-term, certainly we think aspirin offers primary and secondary prevention as well for stroke. So that's something that's why we use for these patients with a small benefit, with a small risk of hemorrhage as well. Yes, doctor.
Gary Friedman again. You mentioned we were talking about the intra-arterial infusion of TPA after thrombectomy. There's some very old literature talking that the anterior circulation stabilizes at 24 hours. I'm just wondering if the microemboli are the physiologic process that underlies this until it stabilizes, perhaps?
Yeah, certainly that's one of the proposed mechanism for the so-called stunned brain, because the so-called mesoid perfusion, this metabolic profile of the stunned neurons are still low, so they are actually not requiring the blood flow, the energy delivery. So the blood flow is very slow. We see this on angiogram. You recognize vessel, it takes longer for them to get to the area. So that's where they can have stagnation, have microemboli, everything, the mesoid perfusion. So that's why the post recognition IE thrombolytics may be helpful.
Thank you.
Welcome. I think we have to hold the question until the breaks. If I make 15 minutes. Some questions. Do we have time?
Yeah, we have like 10 minutes.
Okay, sure. I guess I finished ahead of time, which is rare.
Dave,
Well, I know there's a question in the audience.
Dave Ledoux from Northwell.
Welcome.
That's great work. Thank you. From great work on the minocycline. We used it for also STA and MCA bypasses. But what's interesting is looking at the mechanism of action of the minocycline, specifically for nitric oxide synthetase inhibition. I'm just wondering, preserving the penumbra, naturally when an area of ischemia, the core infarct, there's nothing to really preserve, but that's the penumbra. By inhibiting the nitric oxide synthetase and inhibiting nitric oxide, would that have an effect more of a vasoconstrictive rather than a vasodilatory response to that area? I just understanding the mechanism.
Yeah, so I think that's very interesting. Some of these research are, paradoxical. You think it's be one mechanism as opposed to, constriction or vasodilation. I don't think we fully understand, how it really works, and especially in clinical setting. Now, you would think the vasodilation may be helpful, but on the other hand, vasoconstriction at the time will maintain the blood flow, blood pressure in a certain degree, maybe preserving the area that distally. So we don't know really what is at play. That's why the additional research will be needed.
Yeah.
Very, very interesting question.
Yeah. I also was, you wonder too, if there is a vasodilatory effect, does it decrease the risk of hemorrhage?
Right.
Post-infarct hemorrhage. I mean, maybe that's a possibility, and that's an area to look at.
Right. So that's what we, clinically we see, minocycline appear to be more protective in the hemorrhagic patients.
Mm-hmm.
More effective. The protective effects more. So maybe something over there has the benefit.
Thank you.
Welcome. So there are a few questions online. Are there studies regarding minocycline use in hemorrhagic stroke or other neurodegenerative disorders such as PD or AD? So there are a number of studies in the publications, in the literature. You can search. You can Google. Google, or you can search the clinicaltrials.gov. There are ongoing trial studies too, including minocycline in post endovascular treatment as well, by a group from SUNY Buffalo in upstate New York. So there are different studies. There's also study in Singapore and elsewhere. Some of the trials done but never published. I presume there's negative data. Didn't achieve the functional or safety outcomes. So there are still a lot of things need to be done. But I believe this is the first time that anyone has shown minocycline has any effect on mortality, overall mortality, as opposed to functional improvement, as most stroke trials are designed to achieve. Good morning, Dr. Wang. Holly. Oh, hi, Holly. Welcome back. Holly was one of the nurse practitioners who's here, worked with us for a long time before he moved to Mount Sinai with Dr. Rudolph. How many of minocycline patients had COVID? Great question. We actually controlled the COVID population after the COVID period. So we excluded all the patients. Not many, not out of the, it did contribute to a certain degree to the mortality, but we excluded those patients in the 2022 population for our study. Sandra McBride, thank you. How can you tell whether a clot is fibrin rich or opposed to RBC rich? We can't really tell when the clot is a vessel, although you do see so-called hyperdense vessel signs on imaging, my MCAs and Basler. So presumably the denser vessels are more likely to be fibrin rich as opposed to less dense vessels. But after we remove it, we can certainly tell so-called the white clot or red clot. Red clots are the red cells rich and fibrin less clots. And then we can tell by how many passes you have to pull to get clot out. So fibrin rich clots are like a rubber in there. You have to go multiple times to pull the clot out, as opposed to the red blood cell that can pull out very easily in one, sometimes using only aspiration without stand retriever. The red clots also will easier to just to embolize. Okay, so I think I used up all my time. I hope you have any questions, we'll be able to answer in the Q&A in the break or at lunchtime.